Okay, employers, the most powerful tool we have to control costs in healthcare just got a whole heck of a lot easier. There's been rumors of this for well over a year. I've alluded to it in some of my posts here over the last, I don't know, a few months, but it's official, it's public, and I'm about ready to scream it from the rooftops if we can. So, obviously, what do we think the most powerful single tool we have to control healthcare costs for an employer? It's self-funding your health plan and specifically self-funding your health plan with reference-based pricing. So I'm going to go into just a quick review of what that is because I often get accused of being a little too hip for the room. You know what I mean? Like jumping ahead to the advanced course for people that are like, what is RBP? So when you fully insure a health plan, you're always going to pay the most. Always. Now, when I say always, I mean over any 5-year period, right? Because you could certainly have a situation whereby you have a really bad year and having that insurance saved you money. That's what insurance is supposed to do. It's supposed to alleviate those large risks that we cannot plan for, right? So, but when you look at any 5-year period, as long as you have more than, say, 250 employees, you're always going to save money when you self-fund. I mean, the most simple answer for that is, well, carriers have to make a profit, right? So if you're paying an insurance carrier to cover your plan, they have to build profit into their underwriting. In addition to that, PPACA, the Patient Protection Affordable Care Act, often called the ACA or the Affordable Care Act, or also called Obamacare, put in a medical loss ratio mandate for large groups. And what that medical loss ratio mandate said was 85% of the money that an insurer, fully insured plan, takes from an employer must go to the payment of claims. Now, the details on how this works, it's a state-by-state thing, and what they can include in claims and not gets quite fuzzy. I won't even go there. Let's just take this on its face. So what that means is an insurer can only make a 15% margin on top of claims, right? State by state. They have to underwrite their plans such that they don't make more than 15%, because if they make more than 15%, they actually have to rebate that money back to the policyholders in the states. So, again, no good deed goes unpunished, one of my favorite sayings. This was thought in 2009, 2010, when this was written and then passed, that this would be a good way to keep the insurers from price gouging and profiteering on employer plans and policyholders, because there's also a metric in the individual and the small group market as well. But the reality is what you did is you perverted the incentive to keep claims costs down, because now an employer's in a situation whereby the only way they can grow their revenue, that 15%, is if the claims grow, right? If you tell my 12-year-old granddaughter, if you tell her, you're only going to get to eat 15% of this bowl of ice cream, she's going to say, I'm going to need a bigger bowl, right? I mean, that's the simple thing. So what happened with PPACA on a fully insured basis was you put this mechanism in, and that 15% that the carrier gets to keep, I mean, 15, they have to pay brokers out of that. They pay costs out of that. I mean, their profit is probably more in the range of 4 to 8%, depending upon how efficient they're running. But you get the idea. So look, you can't always self-fund because you might be too small, right? If you've only got, 17 employees, basically it's impossible to self-fund. We really try to only self-fund groups with 250 or more employees. We certainly can self-fund down to 100 with captives and other creative things that can be done. But you got to self-fund in order to remove this giant profit center from your plans, the middleman. And I get that not everybody can do that, but okay, self-funding, right? So then what's next? All right. When you fully insure, okay, hospitals and insurance companies agree to charge you 2 to 3 times a reasonable amount for hospital services. To make this look like a great bargain, hospitals publish charge master prices at 4 to 8 times reasonable amounts so that employers can feel good about getting a 50% discount when they purchase that insurance. The federal government is ultimately fine with this egregious price inflation, as it permits politicians to keep the Medicare and Medicaid prices artificially low and then proclaim that they're doing a great job at refining and reining in prices. Okay, so what's going on here? When you insure your health plan, employers, basically hospitals have these published rates now that are becoming more and more transparent as the law requires it. Now, the law required it years ago. A lot of hospitals are just thumbing their nose at the law because the fines are sufficiently low that they would rather be fined than tell you exactly what their real prices are. Think about that. So hospitals are in a situation where they publish a rate, a charge master rate, a market rate, what we call. No, nobody actually pays this rate, by the way. It's completely fictitious, but they publish a rate, and that rate might be 4, 6, 8, 10, 12 times actual cost, or an actual cost is usually a little bit less than what Medicare would pay, or you could say it's like 4 to 10 times what Medicare would pay for the same service. Okay, so you've got this giant. We'll just say it's 8x. You've got this giant cost of 8x. So an insurance company and a hospital get together and say, well, look, we'll bring you our insured patients, we'll bring you the employer's employees. However, in order to do that, we're going to require that you give us a discount off of that 8x number. So they might take that 8x number and cut it in half and say, okay, now you get a 50% discount by coming with insurance company A. That 50% discount is still 4 times cost, or maybe 3 times what Medicare would pay. And in point of fact, in California, it's roughly, employers pay approximately 311% of what Medicare pays for the same exact services at that hospital. All right, so facility charges make up the largest piece of an employer's claim cost. If you fully insure, you're just paying this. There's nothing you can do. You're paying 311% of what Medicare pays, maybe 400% of the actual cost. You're just eating that. Now, you don't necessarily see those items, right? Because you're fully insured. So you're just handing over the insurance company a very fat check to cover your employees. So the first thing you have to do is you have to self-fund your plan if you can. Again, more than 250 employees, and geography matters too. I totally get it. But idea being, buy as little insurance as you can. The more insurance you buy, the more you're getting ripped off. It's that simple. My job as a consultant in this world is not to sell you insurance. My job is to show you how to minimize the damage insurance does to you. All right, so that's the first step. Then if you do self-insure, what a vast majority, something like 96, 95% of employers that do self-insure rent a traditional PPO network. So they go and they rent a network from one of those large insurance companies so they can get that 50% discount, right? So they can take that 800 times Medicare charge and cut it to 400%. Woohoo, what a bargain. Yeah, it is beyond a scam. I hate to say it, but it just is. It's really a bad deal. There's just no other way around it other than to say hospitals dig it because they're able to charge a ton of money and be anti-competitive effectively. Insurance companies like it because, with Obamacare in place, they got to grow that claim cost one way or another. And one way to grow it's to pay 300% of what they would pay, what Medicare would charge for the same claim. And then the federal government doesn't have any real problem with this either because it allows the federal government to keep Medicare and Medicaid costs artificially lower, particularly Medicaid, because hospitals that are maybe even losing money treating Medicaid patients can make up the difference by issuing 8, 12, 16, 25% renewal increases to you, the employer. It is a shell game. And the best thing you can do is to exit it. You've got to get out of this. Okay, so what does reference-based pricing do? How do we attack this issue with RBP? RBP is just a form of self-insuring that removes insurance companies and traditional networks from the plan. All right? Remember, that insurer has to make a profit, and they're really, really good at it. We can't beat them. We can, again, I can minimize the damage they do to you, but we can't win. Over any 5-year period, the insurance company is going to win. In point of fact, it has to win. It has to stay solvent, right? In any one of 5 years, yeah, we can win. The employer can win. You can have claims that exceed your premium. Great. Over 5 years, you lose. And the longer you do it, the more you lose. All right. So, and remember, those discounts aren't discounts at all. So, yeah, I'm going to pay you for a discount of 50% off something that's been marked up 6 to 8 times. Not a discount, right? So with RBP, you just cut out that middleman. Now, you pay the physician or the hospital a fair price. You pay them a reference price, a price tethered to a reference point, hence the name. Most commonly, we end up paying the physician or the hospital 25 to 60% more than Medicare. That varies, again, by geography. It varies by specialty, like anesthesiologists. You have to pay them more to get coverage. For labs and x-rays, a lot of times you just pay like right at the Medicare reimbursement and you're good enough. It just depends. You've got to have the experts in your corner that know how to do this. The other way to do it is to pay a set percentage above the actual reported cost. So another kind of secret out there is that if a hospital wants to get reimbursed by the federal government, Medicare or Medicaid, right, they have to report their costs to the federal government on a regular basis, and they do. And you can pay a subscription fee and get access to all of this information, which we have. So we know, for example, that the hospital right there in your neighborhood, whatever hospital it is, we know exactly what they report as a cost for everything they do. Every CT scan, every x-ray, every MRI, whether it's an x-ray of a shoulder or a collarbone or my noggin, right? So anyway, okay, so we know what the cost is and we know what Medicare would pay. That's all public information. So what we do is we say, all right, we'll pay you some percentage more than that, 25, 40, 50, 60, whatever we need to do to make sure you, provider, are compensated fairly, but we, employer, aren't paying 300, 400, or 500% of what Medicare would pay, which is what the healthcare cartel likes you to pay. All right. It like sounds too good to be true, right? Yeah. That's what I thought when I first heard about this, probably a dozen years ago now. So RBP did begin as a very simple concept. It was, here's what we're going to pay you. We're going to ram it down your throat, eat it, like it. And then if you don't like it, talk to our lawyers, right? Because we're going to fight over it. So it's been around for more than a dozen years now. There are some entities that I guess 2008-ish is when most people kind of agree that it started. Really, it's kind of been around popular for about a dozen years. But anyway, it started off as just that. We're going to reprice the claim and then talk to our lawyers, right? We'll go fight it out. It's changed dramatically in the past 4 to 6 years, but it's now to the point where it's changing dramatically month by month, literally month by month. Every few months now, the changes are so severe that I'm like, wow, this is insane, because now we're seeing people in the industry have embraced it at one level or another. That'd be stop loss providers, TPAs, concierge services, even some insurance companies are now embracing it. And oh my gosh, even some hospitals are embracing it, or at least have softened their stance against it, let's say. So Cigna, Aetna, Anthem, Blue Cross Blue Shield, right? and UHC will all now work with reference-based pricing in one way or another. But the biggest news, the very, very biggest news, has just become a reality. Yep. Okay, but first, how does RBP save money? All right, well, look, with RBP, one thing that's really important to remember is we're not attempting to cut what a doctor receives. Physicians are usually quite happy to get 120 to 160% of Medicare, because that's not too different than what they get with the large carrier network they're in now. The physicians, the doctors, the providers, they are not the problem in your health plan. They are not the egregious high costs that are driving your renewals up by 10, 20% every single year. They aren't the issue. So with RBP, all of the good ones anyway, all of the good providers, and there are more than a dozen RBP repricers out there now, folks. We pay the docs either roughly what they get paid now or even more in some cases, right? So just take doctors out of the mindset that, we don't want to hurt the family doctor. It's hospitals where you pay this amount of money. The problem is our system in healthcare in America has grown this way over about 100 years. So we've gotten to the point now where if you don't have one of those big logos on your card, like on the past slide, right? The Cigna, Aetna, Anthem, United Healthcare, Kaiser, Sutter, if you're local in Northern California. If you don't have one of those logos on your card, a lot of times at the front desk of the doctor's office, the person goes, "Oh, we don't take this," or "We don't know what this is," right? So you do have this problem of, I want to reference-based price my plan. I want to save money. I don't want to gouge doctors. I want to pay them fairly. But I also don't want my employees to get pushback when they go to the doctor's office where they get a front desk person who says, "I don't recognize this logo. We don't take this." Okay. Now, look, we've been doing this for years. We have systems in place to assuage that issue, to overcome that issue. And in fact, we do dramatically in almost all geographies with almost all providers. We have solutions for that work incredibly well. But the easy button has now been hit. Almost any old broker can go sell RBP now. Now, they can sell it, but can they manage it? Can they run? That's a whole different broker, consultant, agent, whisperer, recommender, advisor, whatever we want to call them in the vernacular of today's day and age. I have to say that in every video, folks. The fact that, oh, broker's a bad word. We got to come up with a new one. And we just keep coming up with a new one every 5 or 10 years. It went broker, consultant. The really in vogue one now is advisor. That'll get sullied at some point, and it'll be a whisperer or a recommender, right? Good Lord. All right, I'm sticking with consultant. It works for me. So if you happen to have a corporate headquarter in one of these states, and you've got 250 employees, again, can you do it smaller? Yeah, but it gets so tough. It's a mess. Let's talk about the large employers. If you're in one of these 14 locales, RBP just got really, really easy, folks. I mean, like easy button. Like, we're going to go from 4% of the market doing this to 8% pretty darn quick, I think. There it is. You might be saying, well, what's special about these states, Craig? Why is it okay in these states? And of course, those of you in the industry know, because there's been rumors of this for like a whole year, and it's been buzz and buzz and buzz, and there's letters and there's stipulations and there's all this stuff out there, and fantastic. Here it is. Anthem did it. Anthem got in bed with RBP in a big way. So I think I put this meme out in May or April, something like that. And of course, a lot of people had probably no idea what I was talking about, but yeah, it's that weird. It would be as weird as if you saw AOC and former President Trump just tonguing right in front of you. Anthem is all in with a provider, a PON, a provider-only network for RBP in those states. Now, there are other stipulations. There are some size requirements. There are some PBM requirements. They have some stipulations about, which plans they will take and won't take, et cetera. But it's out there and it's available. And you can see Melania, who I've labeled as Sutter in this meme, is not that happy about things. Sutter probably doesn't even know what's hit him. Sutter probably doesn't even really know what's about to hit him yet. But here's the deal. So far, all of those national carriers, all those ones you saw listed, right? They haven't been able to do RBP, not because they particularly necessarily entirely care about renting their network out on the provider side, but because the large hospital chains, i.e. the Sutters of the world in Northern California, have said, oh, no. We don't carve our docs out. If you want access to our network pricing and our doctors, you have to take our doctors and our hospitals, right? Because they know they're making all the money at the hospital level. They're making the money on the 300 to 400% of Medicare or costs that they're charging you at the hospital level. They're not making any money at the doctor level. I mean, they are, don't get me wrong, but it's not the driver, okay? So Anthem has really broken the mold here. I don't know how long this is going to be available. I hope forever. They're already doing it in some states. In California, it's starting this fall. Banana Town. Because what Anthem is doing is they're saying, we will sell you just our doctor network, not the facility pricing. So you can put that beautiful Anthem logo on your card, and we'll charge you, by the way, roughly half of what we charge to rent that network normally, because you're not using the facility network. And all of your employees will now have an Anthem logo on that card when they go to the doctor, which is what 90% of us do. Only about 10% of people are hospitalized in a given year, but that's where all your costs are, in the hospitalizations, right? So what's the advantage of this? Well, the advantage of this is the biggest knock on RBP, the one thing that made people afraid of it for the most part, was this access issue. Employees showing up just for their 1 or their 2 or their 3 doctor visits per year and getting somebody at the front desk that says, I don't know what that is. We don't take that. Solved. Now you've got probably the most recognizable Blue Cross Anthem logo in the country. So every doctor's office, well, every doctor's office that takes Blue Cross Anthem is going to say, okay, yeah, Anthem, we take that. And why is this okay for an employer that wants to save money? Because remember, at the doctor level, we're paying them roughly 120 to 160% of Medicare anyway with RBP. Now we just do it under the Anthem logo because the Anthem reimbursements are roughly the same at the provider level. So we're not costing the plan hardly any money to do this. I mean, we're paying a PEPM to rent a network, so we are paying a small fixed cost for the access to this logo on the card. So you go RBP for the first time, throw the Anthem logo on your card, make it easy, make it so that you're not going to have access issues. They're going to recognize that card. They're going to take it. 90% of your claims are going to flow through as they do today. And now you only have to apply reference-based pricing on the claims that matter, and that's at the facility level, the hospital claims, right? It's such a huge deal, folks. Now, after you do this for a year or two, you might, as an employer, decide, heck, I don't even need that. Like, these doctors' offices we have working with us now are familiar with our plan. We're going to still pay them a fair amount. Why pay Anthem this PEPM, this fixed charge we have to rent this network? We could get rid of that cost too. More power to you. In fact, a lot of my plans have zero network at all, zero provider network. Some do, some don't. It's awesome. It's just, this opened it up, opened the floodgates in a massive way for RBP to become just darn near easy button, right? I mean, darn near. I mean, there's still quite a bit you want to know in RBP to be able to do this, but so hence the meme. My prediction is this is going to work as long as the Sutters of the world allow it to work. But eventually, what's going to happen, I think, is the large hospital chains that are used to charging you 600% of Medicare are going to say, we hate RBP. We don't want you doing this. So if you would like to use our network now, you can't do RBP anymore. You can't have a provider-only network. Now, that fight, I think, is coming down the road between Sutter and Anthem, as an example. And it won't just be Sutter, it'll be all the higher cost, large hospital networks across the nation that are going to get ticked off at this. So then what'll happen is Anthem eventually will probably create 2 networks, a full network and an RBP physician-only network. And that RBP physician-only network won't include the highest cost providers in the area, i.e. something like Sutter, right? I think that's where it ends up, and then you end up with, well, gosh, that just looks like PHCS anyway, which is one of the larger networks that you can use with RBP. Anyway, enough said. It's interesting, and here's the deal. While it's available, let's use it. While it's available, let's spread RBP. Let's get those savings for you, employers. They're out there to be had. Okay, so it's beyond a game changer. Like I said, employees now have an Anthem logo on their card. They're not going to have any access issues for the 90% of time that they go to the doctor where it's not an inpatient hospital visit. And the employer gets to reference-based price the single most costly aspect of their plan without paying 300% of what Medicare would pay for that service. All right. Thank you, folks, again for a great day. Until next time, keep reference-based pricing your plans.